Hello, everyone. Welcome to today's webinar on people experiencing homelessness. My name is Carl Amrit, and I'm a senior policy analyst on the National Governors Association's Homeland Security team. Today's webinar is hosted by the National Governors Association in collaboration with the American Bar Association as a part of a four-part series on equity and policy preparedness during public health emergencies. This work is funded by a cooperative agreement between the NGA and U.S. Centers for Disease Control and Prevention. The presentation content does not necessarily represent the views of NGA or the CDC, and the information presented should not be construed as legal advice or guidance. During today's webinar, we'll examine the services available to people experiencing homelessness in the context of public health emergencies and the way in which laws and policies can both protect or negatively impact this at-risk group. Our speakers will discuss how public health emergencies can exacerbate homelessness itself, how they can intensify chronic and acute consequences for individuals experiencing homelessness. We will also examine how people experiencing homelessness tend to have a higher prevalence of pre-existing conditions that increase the risk of experiencing poorer outcomes once sick. Additionally, overcrowding and unsanitary conditions in camps and shelters may increase viral transmission among people experiencing homelessness. Finally, we will discuss the policies that can be put in place for the ongoing COVID-19 health emergency to protect these individuals. A few housekeeping items before speaker introductions. This webinar is being recorded. The recording will be posted on NGA's website at nga.org/webinars. Everyone has been muted to minimize background noise. We are holding all questions until the end of the webinar. If you want to ask a question or participate, please select mute or unmute button at the bottom of the screen. If you experience technical difficulties, please contact myself at camrit@nga.org or utilize the chat box function of the webinar. Today, we have a fantastic group of speakers who have agreed to join the webinar today to share their perspectives on the work that they're doing in this area. In the order, we'll be hearing from Olivia, visiting senior fellow from the Center on Budget and Policy Priorities. Then Dr. Barbara DiPietro, Senior Director of Policy at the National Healthcare for the Homeless Council, And finally, we hear from Haley Pfeiffer Haynes, Chief of External Affairs in the North Carolina Office of Recovery and Resiliency. I'll ask our speakers to forgive me in advance for messing up anyone's names and correct me during your time of the presentation. We will follow the presentations with a question and answer period. I would like to thank all of our speakers for being with us today. I am so excited to hear about the work that you're doing in this area and the work that governors can take back to their jurisdictions. And with that, let's get started. To begin, we have Anne Olivia. Anne Olivia is a visiting senior fellow from the Center on Budget and Policy Priorities. She came to the center from the Corporation for Supportive Housing, where she has been the senior policy advisor to the CEO since 2018. Prior to joining CSSH, Ms. Olivia was a Deputy Assistant Secretary for Special Needs at the U.S. Department of Housing and Urban Development, where she oversaw a multi-billion-dollar portfolio that included the department's work on homelessness and housing for persons living with HIV/AIDS. Anne, please take it away.
Great. Thank you so much, Carl. I'm really excited to be here today, especially with my esteemed colleagues who are on the panel with me. I've followed the work that's happening in North Carolina and have been just so impressed in terms of what they've been working on and doing both during natural disasters and during the COVID-19 pandemic. And of course, my colleague, Barbara DiPietro has been just an incredible partner in this work as we have tried to figure out how to serve people experiencing homelessness in the best way possible during this pandemic. So thank you so much, Carl, for having me. I am hoping that I can, it'll just take a second, I think, for the slides to switch. So let me give it another second. But I'll start out by saying, you know, I'm going to provide some broad context on the work that we've done nationally. And I'm specifically going to talk today about a project called the Framework for an Equitable COVID-19 Homelessness Response. And that project really has been a pleasure to work on because it has pulled together a number of national organizations and experts on the issue of homelessness and healthcare to focus in on this particular area while centering all of the work on racial justice and equity. So you can see on the screen here, the list of the national organizations and experts that have been working on this particular project. And it's a pretty impressive list, including Barbara, who is with us today, and 2 former U.S. Interagency Council on Homelessness executive directors. But we always start this conversation with the data. So as we, you know, I don't want to spend a ton of time here, but I do want to just make sure that we're setting the stage. And obviously I'm talking today with folks who are managing state government work. So I would take all of this federal data and actually break it down at the state level if I was working in a state government. But we know the number of people who are experiencing homelessness at a point in time in the United States is alarming. In 2019, which is the most recent federal data that we have, you can see the blue line here is all people experiencing homelessness, more than 567,000 people experiencing homelessness at a point in time. But really the story here for today's conversation is that green line at the bottom. And what you can see there, that's people experiencing unsheltered homelessness. And you can see that unsheltered homelessness since 2015 has been steadily increasing. And this was something that we were really concerned about, especially in the early days of the COVID-19 pandemic. And then you can also see that we have a lot of people in 2019, 356,000 people in shelter on a given night. And all of those shelters needed to be very quickly reworked to be able to be in line with CDC guidance. But obviously this is only part of the story. This is the point in time data. At any, you know, over the course of a year, those numbers look different. And it's more like 1.4 million people experience homelessness, at least sheltered homelessness, over the course of a year. So that means 1 in 228 people in the United States experiences sheltered homelessness over the course of a year. So I just want to give you that broad idea of what's happening. And then the other thing we need to look at when we're thinking about COVID-19 response, both on the economic side and on the public health side, is who is making up those people who are experiencing homelessness. And you can see here the breakout between individuals and people and families, and who's sheltered and unsheltered in those categories. So the story here really is that we have a lot of unsheltered individuals. Families tend to be in sheltered locations or in doubled up situations. So that's another thing that we need to pay attention to when we're thinking about homelessness prevention and diversion. But this gives you a more complete picture. And then the third thing that I want to raise in relation to how you should be looking at your data at the state level is that we know, based on research done by Dennis Culhane and his colleagues, that people experiencing homelessness, the age of that population is increasing. So in 2010, sheltered adult males, for example, were much older on average than they were either in 1990 or 2000. So we have a cohort of people where the average age is going up and up over time. And this is particularly concerning when we're talking about COVID-19 because this is a high-risk group. And again, I'm referencing some data that was analyzed by Dennis Culhane and a number of his colleagues early on during the pandemic. They took a look at what it might take to actually create enough capacity within the homeless assistance system, both by creating space within current emergency shelters to socially distance and follow CDC guidance, and to get people experiencing unsheltered homelessness into safe non-congregate shelter. And when they did this analysis, they really came to the conclusion that the need or the cost related to this need would be about $11.5 billion over the course of a year. And in the CARES Act, you know that the Emergency Solutions Grants Program received about $4 billion. So there is quite a gap that still has to be closed. And we're really hoping that there's another COVID relief package moving forward soon that will address the needs for people who are experiencing homelessness and get critical funding into the hands of state and local grantees. And then the other thing that we would really encourage folks to look at and to think about, and as you're doing this series around equity, it is incredibly important for folks to be looking at their data in a disaggregated way so that we can see what the impact of all of these decisions are on communities of color and communities that are highly impacted by both homelessness and COVID-19. So we know that communities of color have been disproportionately impacted by both the virus itself and the related economic impact. So we need to be able to create programs and policies that address that disproportionate impact. And then we also know that communities of color are disproportionately impacted by homelessness. So this is truly sort of a crisis that, that state and localities have to address as they're doing their program planning. So that said, we created this, this framework for communities to use that is really grounded in racial justice and equity principles. And once we looked at all of that data and we understood what the challenges are faced by communities all over the country, we created a set of principles that would guide our work. And these are those principles. We want to advance racial justice and equity first. We want to make sure that we're addressing the needs of people who are high need also first. So people who are unsheltered, who are older, disabled, or medically fragile. And I know that Barbara is going to get into sort of the health side of this conversation in a much deeper way. But we want to make sure that we're addressing their needs first. We want to create new partnerships and grow the partnerships that we have. For example, we want to make sure that we're getting into high need communities, very impacted communities. And sometimes that means that we're partnering with new folks that we've never partnered with before. Obviously, we want to get people into housing. This isn't just about shelter. And in fact, emergency shelter, as you'll see in just a moment, is actually not the thing that most people who are experiencing homelessness want. They really want housing. So we want to make sure that we are getting people into housing as quickly as we can, because housing is in fact healthcare. And then we want to not do business as usual. We want to act as quickly as we can, and we want to provide the tools to communities to do that. So these were the principles that we used to guide the development of the framework. And the framework is structured around 5 action areas. So if you download the framework, which I'll put the link in the chat when I'm done presenting, when you download the framework, it's actually a pretty meaty document with lots of information, questions, things that you should be thinking about at the local level, both program design and policy, as well as funding opportunities to fund those things that we need. But it's really focused in 5 action areas. First is people who are living in unsheltered locations. What activities do you all need to focus on in order to address the needs of people in unsheltered locations? The second one is shelters. Many communities rely on congregate shelters, which, as we know, have not been the safest places or most pleasant places for people to be during this emergency. So how can we stand up? And I know we're going to hear what North Carolina has done in this area. How can folks really stand up non-congregate shelter options as they're moving forward? How can you prioritize activities around housing, and housing being the third sort of action area that we want folks to be focused on, getting people out of non-congregate shelter and into housing options as quickly as possible? How can you divert people from the homelessness system overall and prevent their homelessness with the resources that we have? And then thinking through all of the things that we're learning as we're going through this particular crisis, and packing them in the back of our mind to make sure that we are taking those learnings and that we are strengthening our systems to prepare for future natural disasters or other types of crises. So on the website, you'll see that there's the framework itself, which again is a very meaty document, but there are also a number of materials that are designed to support implementation of that framework. And they range from a document that I'll just show you a screenshot of in just a minute that will help communities to figure out how to put the puzzle pieces of funding together in the most comprehensive and strategic way. There's a video that goes along with every product that we put out. We put out a video that explains it and that talks a little bit about why we thought it was important to do that particular product. So there are a number of tools here that really are designed to help communities move forward in their implementation of their COVID-19 plans. And here's one, just a screenshot of one that is particularly, I think, could be particularly useful at the state level. And this is a matrix that will help you sort of at a glance prioritize the kinds of funding that you can use for different kinds of activities. And what it does is it asks you through 4 fairly simple steps, some questions, and helps you determine how to use the different types of funding that are available to you. And the first question, the way this is all contextualized, is whether there is a high level of unsheltered homelessness in your community or a relatively low level of unsheltered homelessness in your community or state. And then from there, it helps you figure out how to use your coronavirus relief fund, for example, or your ESGCV dollars in different ways to get at all of your needs. And I'm going to make a plug here just for a second. A couple of days ago in the Washington Post, they ran a story about states having quite a bit of coronavirus relief funding left because folks have been sort of holding it for different reasons. And I would encourage anybody who's on this call who has coronavirus relief funding that's going to expire at the end of the calendar year to take a look at this matrix and see where the gaps are in your system for people experiencing homelessness so that we can address their needs and use those coronavirus relief funds by the time that they expire at the end of the year. Another really important tool that I think states could use in really meaningful ways is the Urban Institute. And again, I'll put this in the chat when I can. The Urban Institute, as part of this framework project, released an online tool that helps communities really target their homelessness prevention and eviction prevention resources. And here are just 2 maps that I pulled up. One is Richmond, Virginia. The other is the Chicago metro area in Illinois. And the darker the blue, the more need there is in those communities. And they used a number of indices to help them determine need, including a racial equity index, a COVID-19 impact index, and a housing instability index. So combined, those three indices really can show communities down to the neighborhood level where their funding could be most effective and where they can target those dollars. So I would encourage you all to also take a look at that tool as you're thinking about how to get the rest of your funding out the door. And this is just a screenshot of an action area B, which is shelter, from the tool itself, or from the framework itself, and really just shows you what the kinds of resources and ideas that we have in the framework that will help you all figure out how to use your funding most strategically. We also want to make sure that all communities are using the framework in an equitable way, and have a number of tools that will help communities and states to do equity-based decision making. And we actually, from a government perspective, actually lay out a number of questions that state governments or local governments can use to make sure that they are making the most equitable decisions possible. Another piece of the framework is, and I mentioned this earlier, is that we actually, because we are sort of steeped in racial justice and equity approaches, we made sure that we talked to people who are experiencing homelessness and impacted by COVID. And through 11 focus groups that we held over the summer, really 4 big themes emerged. And we want all of our communities who are thinking about how to spend their funding to know what these 4 themes are. And the first is, we talked about emergency shelter. We really want to think about emergency shelter in different ways, especially during the pandemic. If we're funding additional services and new housing options, make sure they're dignity-based, and you ask people who are experiencing homelessness what that means to them. Affordable and supportive housing should be prioritized for communities that are most impacted by COVID-19 and homelessness. And we want to make sure that we're not criminalizing people who are experiencing homelessness, and that police aren't the front line of outreach for people who are experiencing homelessness. So those are the themes that emerged from our listening sessions. Every single product, I'm not going to spend a ton of time here, but every product that we have in this framework has a racial justice and equity component. So we talk about equity-based decision making and lived expertise, and how to include people with lived expertise in your planning in every single product that has been released. And then the last thing I really want to focus on is this idea about planning for the future. I hope that we never have another pandemic like this again, but I think that we have to be prepared to be able to address these kinds of crises when they come up. And people who are experiencing homelessness are particularly vulnerable in these kinds of situations. So we want to make sure that we're setting ourselves up to learn from this situation and to be better prepared in the future. And that means that we're institutionalizing racial justice and equity practices. We're partnering with non-traditional groups or people with lived expertise. We're again reimagining shelter and outreach responses, and really targeting our resources to highly vulnerable people. So that is the very high level version of the framework for an equitable COVID-19 response package. This is how you can contact me. And I look forward to seeing the rest of our panel presentations. Thank you so much, Carl.
Thank you so much. And the framework is really an impressive resource with a lot of concrete recommendations for state and local elected officials. I truly hope that listeners on today's webinar will take time to review that framework and take something back to their locality or state. Next, we'll hear from Barbara. Barbara currently serves as the Senior Director of Policy at the National Healthcare for the Homeless Council. In this role, she works at the intersection of healthcare, homelessness, and housing to advocate nationally for healthcare and housing as human rights. She holds a master's degree in policy sciences and a doctorate in public policy, both from the University of Maryland, Baltimore County. Her dissertation research focused on the impact of homelessness on emergency departments in Baltimore City, and she continues to work to ensure that healthcare systems can better serve vulnerable populations. For 10 years, Barbara worked for the state of Maryland in the governor's office, as well as the Department of Health, helping coordinate health and human services policy and legislation, interagency children and family services, and the state's 10-year plan to end homelessness. Barbara, thank you so much for being here with us today. You're up.
Thank you so much, Carl, and thanks so much to the National Governors Association for having this discussion today. Really excited to be here with my colleagues. And as Anne said, we're all it's a tremendously exciting and busy time to be working at the intersection, particularly of public health and healthcare services, housing, and homeless services. So want to test my ability to, oh, very good, okay. Just talk a little bit about who we are at the National Healthcare for the Homeless Council. For the most part, our members are federally qualified health centers that serve people experiencing homelessness. Last year, we served over 1 million patients at 300 programs nationwide with about 3,000 locations. And so many of our clinics are located in homeless shelters or our freestanding clinics. We're offering comprehensive primary care, behavioral health, and support services like outreach and case management. So one of the things that we see a lot are the challenges that remain in the system to people getting what they need to be successful and get housed. So just excited to talk today about all the things that we've learned in COVID and then how we can be building on those successes. And so let's see, so just real quick, and as a reminder, and Anne had hit on a few of these as well as Carl on why this is a high-risk group, but we see tremendous levels of illness, disability, and poor health, largely congregate settings that people are either staying or receiving services, and that might be either shelters or encampments. As Anne pointed out, we have an aging population that brings with it more frailty, more healthcare conditions, and special considerations. And then frankly, when you are homeless, you have a harder time following public health advice. So how do you stay at home when you have no home? Washing your hands, hygiene stations are very hard to find. Public restrooms are either closed or really been phased out in many communities. And this is a population that has not historically been well served in our systems. And so there's a history of stigma and discrimination, and that leads to real trust issues. And so when often I have found people are confused when folks refuse services. And so they believe that people aren't ready for housing or they just don't want it. But really it's because so often they have been failed by systems that say that they're helping, that there's a tremendous level of distrust. So how we bridge that is really important in this space if we're reaching a real vulnerable population. Want to talk about what has worked well during COVID-19 and our community responses to date. It's amazing to see that the recognition of the risk levels for this population and the special needs has been consistent across communities. We've seen so many communities that are bringing more partners to the table and more people who are seeing homelessness really for the first time as a public health issue. I've been excited to see the focus on transitioning folks to permanent housing and trying to pass by shelter placements or trying to phase that out as our ultimate goal. I've been really excited to see how many non-congregate isolation and quarantine programs we've put in place. And I'm going to talk a little bit during my time about the service packages and the model of care that we can make permanent there. And then finally, I want to talk a little bit about telehealth. And this has been one of the tremendous successes that we've seen. I know a lot of folks in the healthcare sector are excited about telehealth, but for us serving homeless populations, we never thought telehealth was going to work for us. And when we have been thrown into this quite suddenly, we have found tremendous innovations and successes here that I'm really excited about. Let's see. Okay. So I just wanted to talk about 5 areas around healthcare today. And part of this is because it's not to throw everything in the kitchen sink at you, but mostly it's all of you coming from different states are going to have different opportunities in different areas. Everyone's working in a different policy environment, a different resources environment, and a different way that COVID is impacting your population. So you may see some opportunities in one area more so than others. And so tailoring a response, I think there's a lot of different things that we can be doing. Talking about making homelessness a statewide priority, talking about housing as healthcare, talking really intently about how we're looking at our COVID-19 testing and our vaccine distribution. And then I want to talk a little bit about the non-congregate isolation and quarantine programs and their intersection with medical respite care programs. And finally, I want to talk about the role of Medicaid and how we can maximize that program for our population. So in the context of making homelessness a statewide priority, a couple of action items that if you haven't already taken, you might consider, but identifying homelessness as a specific special population in your state response plans and outlining specific targeted activities for them. So whether it's documenting how many people have attained permanent housing or specific interventions that you want to do to make this more of a measurable goal, I think that can be really helpful. How is it that we're directing our state and local public health authorities and emergency response teams to be working together with us as healthcare providers and other service providers in communities to coordinate response plans and bringing everybody to the table? And as I say this, I absolutely am aware that our local health departments and our state health departments have absolutely been under capacity. They've not been funded in the way that they've needed to be in a long time. And so when COVID hit, they were already at a disadvantage from a capacity perspective. So how is it that we can leverage each other's resources and capacity, given that public health has been underfunded, homeless service has been underfunded, but when we come together, we can really put together a good response plan locally. Third, taking a look at where your statewide task force work is going, and could you have a specific focus on homelessness? I'll say that Governor Kemp in Georgia did this with his statewide COVID response team, and he assigned specifically a task force on homelessness that was staffed by Atlanta's mayor, and that has been tremendously successful in bringing together a statewide response to that. And then finally, focusing, as Anne had talked about, focus on ending homelessness by providing housing and preventing homelessness also by stopping evictions. So this is a 2-track process. Okay, so then second, how can we consider housing as healthcare? So for those who are steeped in the social determinant of health language, this is very familiar to you. But as this graphic shows, there's a lot of things that go into our health status and our outcomes that go beyond just clinical care. And so all of the environment around folks is really what actually contributes more to our health than the doctor or the hospital that we go to. And housing is a key part of that. And so what we found, particularly 30 years ago when homelessness was really starting to become a national epidemic, National Academy of Sciences put out a report that had 3 findings. Poor health causes homelessness, homelessness exacerbates existing conditions and creates new ones, and the experience of homelessness makes it very hard to engage in healthcare. So as healthcare providers, these are the barriers that we navigate in trying to get people healthy. But nothing that we do as healthcare providers works well when our clients are staying in a shelter or under the bridge. We need housing to make our work better. And I can't really emphasize enough the partnerships between state housing and health agencies and the preamble to the CDC's eviction order, which really laid out the public health argument to housing stability. So I'm just excited about some of that there in looking at housing as healthcare. When we shift over to really think about prioritizing the testing and the vaccines, there's been a lot of attention given to how we are conducting COVID-19 testing, what priorities are we giving to different populations. I will say that we have had many of the healthcare for the homeless programs that work with us have been doing large group testing events in shelters and encampments. And this is a really helpful way of being able to get out ahead and stem the spread of this illness in this vulnerable population. And the more that you can be doing that surveillance testing, the more you will identify that canary in the coal mine before you have then a large outbreak at your shelter. Some of the things that we've seen in the testing data is when you can be doing frequent surveillance testing, people have had very low infection rates. However, when we let it go and then it's a cluster that evolves and then you test your shelter, you may come up with 50 and 60% positive rate. And again, for larger shelters with 100 or 200 people, that's really actually the recipe for a disaster. I want to make a big plug for our CDC dashboard on testing data. And so I'll talk about that in a second. But then also we are looking ahead at vaccines. And so thinking about how do we prioritize frontline healthcare and shelter staff who serve people who are homeless and making sure that they're part of the plan for when and how they get that vaccine. And then how are we prioritizing people who are homeless for that vaccine as well, knowing that our staff and our clients are both equally at risk and in some cases present more risk than even nursing homes or other high-risk groups. So I want to come back to the data dashboard here. This is a project that we've been working with the CDC on, and essentially this answers one big question. How is COVID-19 impacting the homeless population? And so in order to do that, we need your help. We need people to be conducting these surveillance public health kind of large scale testing events like doing a whole shelter or a whole encampment at once, but then entering your data results into this dashboard. It's a really short dashboard. I so appreciate that there's 100 different data entry pieces that everyone is doing. It's just a few questions. To date, we've been able to get 277 testing events submitted to this, and we're finding almost an 8% positive rate amongst our clients and almost a 4% rate positive rate against our staff. But again, we know that this isn't including all of the testing events. So if you could please ask your state health authority or your local health authorities to be helping put this data in, because those are the folks that usually have ownership of that data. Next, I want to talk about the non-congregate isolation and quarantine programs. So these two pictures right here illustrate two very different realities. If you are in an area where the only thing that have been able to put together is a large congregate setting, then to be frank, that is better than nothing. But I think COVID really offers us an opportunity for us to think bigger and better and really make more permanent improvements to people experiencing homelessness, that maybe this isn't something that has to be a permanent fixture in our community. How can we really be using the funding that Anna talked about in doing some permanent solutions? And so thinking through how are we retooling our expectations of our programs and of our services, and how do we fund those programs to get the results that we need? So thinking through non-congregate settings, a lot of hotel and motel-based programs. But one of the things that we found very interesting at the National Healthcare for the Homeless Council is how in the franticness of pulling together these hotel motel programs and putting a bunch of case managers and assigning staff into these programs, essentially we have replicated medical respite programs. And for many years, the National Healthcare for the Homeless program has been working to develop and expand medical respite programs, develop standards for these. And essentially these are, as part of the continuum of care in a community, these are venues that are safe discharge options for hospitals when individuals who are homeless no longer need that acute level of care. And so I think many of you are probably familiar with the fact that someone who's homeless in a hospital, they can get better, but until we have a safe discharge program, the hospital can't let them go. Whereas you and I would be discharged home for rest and recuperation. So this is a place where people can rest and recuperate that's not an inpatient setting. The venues can span a number of different models, but the services, the service piece is the most important. And this is wrapping the primary care, the behavioral health, and the support services into these venues so that people have housing stability as well as service stability. And we found that particularly in COVID, there's been a lot of disruption of people getting pulled from place to place. And so getting disconnected from medications, getting disconnected from therapy, from their support systems has been tremendously disruptive. And we are very worried about either COVID-related illnesses or the indirect negative outcomes, heart attacks, strokes, overdoses, relapse, all of the things that are happening because people are under tremendous stress. How is it that we have an opportunity in these alternate care sites, medical respite programs, whatever we call them, to be able to stabilize people's health, but also get them into a better place? And this also gives us an opportunity to work on housing assistance and making sure that this is a springboard into permanent housing rather than back to the street. And so the staff is a mix of clinical and non-clinical, and the funding can come from a lot of different places. And then finally, I want to talk about Medicaid and how we can maximize Medicaid. I think it's really not possible to talk about homelessness and healthcare without talking about Medicaid, because truly, this is the only health insurance program for the most part that we are working with. And I will say that there is a tremendous disparity, as you might imagine, between states that have expanded Medicaid and those who have not. And if you'll see this chart, we served about 1 million patients in 2018. And essentially, it's the difference between being uninsured or on Medicaid. And even Medicare and private insurance is just not as much of an insurance coverage program for this population. So thinking through, Medicaid delivers comprehensive and coordinated services. It allows us to do that within a system of care. When people remain uninsured, it's ad hoc. There's no data structure around them. There's no real team or coordinated system that's looking after them, particularly that you might find like in a managed care setting. And so coordinating that is really important. When we don't have that, it ends up being tremendously inefficient for all of us, expensive for the system, and also ultimately not very helpful for the person experiencing homelessness, who might go through multiple placements at different healthcare settings, and at the end of the day still come out homeless and uninsured. And we haven't really addressed the issues. We've also found in the years that Medicaid has expanded, it's given us an opportunity to see that Medicaid actually, as a program, not only improves health outcomes in terms of people's chronic and acute conditions, but it also stabilizes their housing. Using our waiver flexibilities through Medicaid to be able to add services like tenancy supports and being able to get your case management funded through Medicaid and getting those supports that are so important for making housing work well, you can get those through Medicaid and really maximizing the flexibilities in that program. And I would say that if you look at this, even in Medicaid expansion states, we're not at 100% for this population. And for the most part, while we might not expect to get to 100%, I would say that still 2/3 coverage is not enough. There are still barriers in our program for people attaining coverage and retaining coverage. So really thinking through, how can we be doing at least eligibility to begin with if you're a state that hasn't expanded Medicaid, but looking at continuous coverage, seamless enrollment, and other factors that might make a smoother coverage experience. And then finally, I'm excited to talk about the successes we've seen in telehealth, but specifically, this has been really helpful through Medicaid, and the flexibilities that have been authorized until the end of the public health emergency are the kinds of flexibilities that would not have been possible previously, just because you wouldn't have moved to audio only visits. The flexibility in originating in distant sites, and that's jargon for where the patient is and where the provider is. And so now that we've had so many of our staff doing work from home, we've needed those flexibilities on where these calls can originate. And for our patients, I think I said before, we never thought telehealth could work for us. Our patients don't have phones that have a lot of video capacity and data and minutes to be able to sustain these calls. And so part of it is going to just a traditional phone call where we can maintain our relationships with clients has been unexpectedly successful. We've seen reductions in our no-show rates. And so many of our programs are seeing our missed appointment rate at the lowest level that we've ever seen, because it's so much easier to be able to get folks on the phone and be able to do what you need to do. Now, again, that's not for every visit for every client, but we can do a lot of chronic disease management and a lot of therapy and a lot of medication management over the phone. There's a number of other things here that have been flexibilities in Medicaid that have also been important. But the real key here is that these flexibilities are only authorized until the end of the public health emergency. And after that's over, unless your state has made provisions in your Medicaid program, either through a state plan amendment or through state legislation of some kind, these go away. And it's going to be very hard for us on the front line and the safety net to be able to continue doing this. And so I'm very worried that states are going to get to the end of this. There's no more authorization, certainly no more reimbursements for these types of visits. And then we will be left with real access to care issues, particularly going into the worst of our COVID infection rates. So these are some of the things that I'm really worried about. But I want to stress how important it is to be making provisions now to make these permanent in your Medicaid program so that you've got a nice, smooth transition for when the public health emergency ends. I'm just going to recap just some of the, because I've covered a lot of ground and a lot of issues, but just want to talk about making homelessness a statewide priority, looking at housing as healthcare as a core social determinant of health, being really intentional about how we're doing testing, please reporting that testing into that dashboard, and then thoughtful vaccine distributions for prioritizing staff and clients. And then thinking through the service packages that you have in the short term while responding to COVID and the non-congregate isolation and quarantine programs, but thinking longer term in making those permanent programs, medical respite programs, since you've already got the model and the partnerships and the agreements between service providers there, that's something that you can really build on in your community. And then finally, looking at ways that you can maximize your Medicaid program. At the bottom of many of my slides, I've put resources, issue briefs, fact sheets, kinds of stuff that we've had, that we've published on different topics. I've just listed them all here. I know how hard it is to kind of get resources when you're doing these webinars and the slides and such. So if any of these are of interest, just plugging it into Google, I'm sure it'll pop up. I know the slides will be available. If you also are interested in medical respite care and learning more about that, the National Institute for Medical Respite Care is an initiative of the National Healthcare for the Homeless Council. We would love to talk with you more about how you can really be making that work for your community and making a more seamless continuum from hospital to respite into housing. Here's how to contact me and my organization. And with that, I'll turn it back over to Carl. Thank you so much.
Thank you so much, Barbara. And I really wanted to underscore one of the points you made for our state leaders on the call is to consider housing as a healthcare issue. It's vitally important that we view health as our housing as a social determinant of health, and how that presents a strategic opportunity for state housing and health agencies to collaborate. So thank you so much for your service and thought leadership in that space. Next, we'll hear from Haley Pfeiffer Haynes. Haley is the Chief of External Affairs for the North Carolina Office of Recovery and Resiliency. In her role, Haley focuses on communication and development of external relationships. Prior to joining the NCORR, she served Secretary of State Elaine F. Marshall, first as General Counsel, then as Deputy Secretary of State for 17 years collectively, overseeing major divisions of that agency, including business registration, notary, charitable solicitation, licensing, and trademarks. As a licensed attorney, Haley litigated for 10 years preceding her appointments with the North Carolina Secretary of State, focusing on criminal defense and family law. She's a North Carolina native, born in Raleigh and raised in Hendersonville. Haley earned her Bachelor's of Arts degree cum laude in political science from North Carolina State University and her Juris Doctorate degree from the University of North Carolina School of Law. Haley, the floor is yours.
Got to unmute myself. Thank you for that introduction, Carl. And I'm happy to be here with you today to talk to you about the HOPE program, which is our Housing Opportunities and Prevention of Eviction program. Just see if I have control yet. Yeah, there. All right. So first, I'm going to talk a little bit about my agency and where we sit in North Carolina government, and then talk to you about a program that we set up very quickly when we got the funds allocated to us by Governor Cooper to help prevent eviction and prevent a whole new wave of homelessness in North Carolina as a result of the coronavirus pandemic. So our office is relatively new. We sit within the Department of Public Safety, and our sister agency is Emergency Management. We were created in the wake of Hurricane Florence in 2018 by Governor Cooper in order to lead the state's efforts rebuilding smarter and stronger following two devastating hurricanes. We manage two types of funding for this recovery effort, CDBG disaster recovery funds and CDBG mitigation funds. And both of those funds are focused on helping folks that are low to moderate income. So when this funding became available, came down from the federal government, the governor turned to us to stand up a program that would help prevent evictions in North Carolina for the many thousands of households that we know would be facing eviction due to the economic hardship that they have suffered as a result of the coronavirus. And we were asked to do this because of our expertise in dealing with these special grant fund types. So initially, we were provided with $94 million in coronavirus relief funds, $28 million in CDBG CV funds, and $66 million in CARES Act funds, CRF funds that come from Department of Treasury that we combined into one pot of money, and that we set up the policies to satisfy both programs. Due to the overwhelming demand that we saw once we opened the program, they allocated an additional $23 million of CDBG CV funds, that's tranche 3 of the CDBG CV funds, and an additional $50 million of CRF funds so that we are at $167 million. And in fact, I think that we will get a little bit more funding to fund everyone that is eligible and that applied before we had to stop application intake. We opened on October 15th and we closed on November 11th. And in that time period, we got a very high number of applications. The need here, as in probably every single state in the nation, is really great. So I want to talk a little bit about the program design, how we designed it in order to reach the most vulnerable populations, to keep them housed and prevent them from being evicted, and also keep their lights and heat on during this time. So the qualifications for this rent and utility assistance is that they have to have been affected economically by the coronavirus pandemic. They have to have a household income. They have to be low to moderate income, which is 80% of the area median income or lower, and that they are behind on their rent or utilities when they apply. Our program pays eligible expenses that were due on or after April 1st. Those would be coronavirus related expenses, or the time frame would match up with coronavirus. And we obviously it is a grant program, not a loan program. We were really avoiding putting people even further behind the 8 ball by doing a loan program. So these folks are getting their rent and utility assistance paid directly, and they do not have to pay any of that back. So in terms of rent assistance, the program pays rent on behalf of the applicant for up to 6 months, and that includes back and future rent. So when I looked at the data yesterday, most people are 2 months behind. And so we pay not only the 2 months that they're behind, but 4 months into the future. And that is done to really provide as much housing stability during the pandemic as we can. So if someone is 6 months behind, we'll pay all that 6 months, but we can't pay more than that. But really, most people, it seems like they have scrimped and saved and maybe paid their rent up through when, you know, some of this higher level of unemployment benefits ran out. And now they are really in a desperate spot. And so that's where we come in. We do pay the rent directly to the landlord, and the landlord has to agree to participate in the program. And that's because we ask them for some concessions in that, which I'll get to in a minute. And we do default to the full 6 months. We really want to pay full 6 months on behalf of anybody who is applying for rent assistance. It's available to folks who have a written lease. And if they have a written lease, we pay the full rent amount. It's also available to those who are going month to month or an oral lease. But at that point, we limit the amount of rent that we pay to the average rent amount in that county. So that if there's not a written lease, we're limiting our potential for fraud or overpayment for someone who is applying for the program. So in terms of what the landlord has to agree to in order to receive this assistance, they have to stop and dismiss any eviction proceedings against the renter and not pass any of the legal fees that they may have incurred onto the renter. They have to agree not to evict the renter for non-payment of rent for the remainder of a written lease or 90 days after assistance ends, whichever is longer. That, again, is a really important piece to providing housing stability for a longer period of time. They also have to agree not to increase the rent or impose new fees during the term of the lease, as well as maintain a safe and habitable dwelling for the renter. In terms of utility assistance, that is available for up to 6 months of past due utility payments. And that is for such things as electricity, water, sewer, wastewater, natural gas, and propane. We considered whether or not we could pay something like someone's internet access bill. Unfortunately, so many of those bills are tied to cable bills and entertainment type options that we deemed that it was not something that our program could cover. So it is limited to those sort of traditional utilities that you would think of. And again, this is paid directly to the utility provider and goes to them directly rather than through the renter. The renter still does sign a grant agreement that they're receiving this assistance, and they have to also tell us whether or not they have received any other benefits so we can make sure that we do not duplicate benefits. So one of the things that we were concerned about, we got allocated this money in August, and we opened the program in mid-October. So it was some really fast and furious work. And one of the things that we decided to do in program design was look to other agencies in state government, that being DHHS, who works with the ESGCV money, to talk to them about their program design and who they're working with for their subrecipients, to work with those same folks. But we also wanted to make the application simple and something that could happen without going into an office. You have to just be conscious of people can't get together right now. It's just not safe. So these are some of the things that are required for applying to the HOPE program. They have to provide their monthly household income, and we allow them to self-certify with that. We're not requiring pay stubs and things like that. If they have it, that's great. But we are allowing them to self-certify in order to streamline determining their eligibility. They have to provide identification to prove identity and linkage to the rented property and or the utilities that are being paid, but we do not require proof of citizenship or immigration status. That is not part of the program requirement. So undocumented individuals, as long as they have appropriate identification to link themselves to the rented property, are eligible for this program. And they have to prove that they occupy a rental. So if someone's applying for just utility assistance, they still have to be a renter. We feel like those are the most vulnerable people. And so our program, even for utility assistance, is limited to renters. We want to see a copy of their lease agreement. As I said earlier, oral leases are permissible and those restrictions apply. But if there is a copy of the lease, we need to have that, as well as copies of utility bills or statements to show what they're behind on and how far they are behind. So we've partnered with 20 nonprofits and local units of government that are engaged in homelessness prevention as subrecipients. And as I said earlier, we started with the group in North Carolina that our DHHS office that administers ESGCV funds, who their subrecipients were. Sometimes in some instances, to get coverage for all 100 of North Carolina's counties, we had to go outside of that list, but we felt like partnering with the nonprofits that have experience with these populations and know their communities was a really good way to go. We also created an online application that was also mobile friendly for anyone who had internet access to be able to apply. And as I said, we tried to keep the application as simple as possible, as less unonerous, I don't know how to say that, burdensome to people so that they could apply quickly. And then for people who did not have access to the internet, we also had 211 accepting applications by phone so that people could apply whether or not they had internet access. One of our accessibility and equity considerations was recognizing that we do have a large Spanish-speaking population in North Carolina, especially in rural communities. And so we provided all of our materials in English and Spanish, including the application and including social media that was sent out as outreach. Our intake was open really just for 3 weeks. And in that time, we received over 43,000 eligible applications. We actually received another 9,700 that were ineligible. So, you know, you're talking in excess of 50,000 applications that we took in at that time. So right now, what we're engaged in is delivering the assistance to renters. The nonprofits that we have partnered with have not seen this kind of volume before, and they haven't seen this level of funding before. And so they've had to build their capacity. And as a result, we also need to build our capacity. So NCORE itself is hiring 125 staff. We've actually, in just over a week, we have hired about 100 temporary staff that are going to begin to move applications through the process, because once applies online, there has to be a contact back with that applicant to confirm things, to make sure everything is updated. And then there has to, if they're applying for rent assistance, there has to be a contact with the landlord to engage with the landlord to see if he or she will participate in the program. And so, you know, there are some moving pieces here, and we really want to make sure that people are not delayed. One of the things that we're doing is seeking to establish data sharing agreements with larger utility providers to expedite the confirmation of past due utilities and issue payments in large batches to them, to really try and keep people from having their lights or heat turned off, especially as the weather here begins to get colder. And one of the things that I think was really super duper important that Governor Cooper did on October 28th, he issued an executive order that protected all eligible HOPE applicants from eviction through the end of 2020, using sort of bootstrapping the CDC moratorium. The order says that if you have applied to the HOPE program and found to be eligible, you are protected from eviction through the end of the year as if you had one of those CDC moratorium pieces of paper, but you don't have to have one of those pieces of paper. And so we think that that was really important in getting landlords on board, because it just made it clear that they could not force someone out even if they decided not to participate in the program. Those folks will still be protected even if the landlord declines. And so I think that is helping to encourage some landlords to reconsider and take advantage of the program. We are carefully monitoring whether landlords are declining to participate in the program. That's something that we are concerned about. And obviously we are concerned about making sure that utility companies understand that these folks are going to be helped. There are people who are being disconnected all the time, and we really are trying to avoid that, so that people can stay in their homes. They obviously, even if they can pay their rent, if they don't have lights, if they don't have electricity, if they don't have heat, they're going to go stay with someone else. So we really viewed this program as a public health measure because people are safest at home, and we don't want to create a whole new homeless population. And as many of you may know, that once someone becomes homeless, it's that much, even if you get them rehoused, they're just at much greater danger of becoming homeless in the future. So we are, this money is being focused in this way to try and prevent an expansion of the homeless population in North Carolina. And with that, I'll conclude my remarks and turn it back over to Carl.
Thank you so much for your informative presentation, Haley. COVID-19 has had a significant economic impact onto states, creating housing instability for thousands of people. And so the HOPE program is truly a model program for states listening in can learn from. So thank you for your service and Governor Cooper's attention to this important issue. Next, we're going to turn to our question and answer period for the audience. If you want to ask a question or participate in the conversation at any point, please select the mute/unmute button at the bottom of the screen or enter your question in the chat box. While participants, I don't see any questions in the queue at the moment. So while participants think and come up with their questions, I have a few to kickstart discussion. First, Anne, I'll start with you. What are some practical ways that states can lead on ending homelessness and COVID-19 recovery efforts for people experiencing homelessness?
Thank you for that question. Yeah, I mean, I think that the most practical things that state governments can do is really set the tone, both for the statewide response and for their local partners as well. So, doing that work that North Carolina and places like California and others have done around strategic thinking, and really making sure that folks see that they are leading on the issues around racial justice and equity as an approach to this work, I think is really important. So like setting a plan at the state level and letting that plan sort of work its way through the different localities, I think is the first most practical thing that state level governments can do. And that has worked, as you heard from Haley, in North Carolina. I know it's worked in California and in other places. The other thing that I think they can do is really look critically at the coronavirus relief funding and make sure that that funding is available for the kinds of needs that we've all been talking about today, from medical respite, making sure that people experiencing homelessness have non-congregate shelter and medical respite available to them, making sure that it's being used again in sort of this most strategic ways, and for things that plug the gaps that other funds can't do. So for example, I would say in most states, ESG CV dollars, that $4 billion CARES Act allocation, those funds really could be, because they are specific to people experiencing homelessness and at risk of homelessness, really focus them in that area, figure out where the gaps are and fill those gaps with coronavirus relief funds. So I would say, like, leading from policy and program design standpoint, making sure that their resources that they control at the state level are filling in those gaps.
Sure. Thank you so much for that response. As a reminder to our listeners, if you have any questions, please feel free to unmute yourself at this time or to enter your question in the chat box and we'll get to it. Haley, in a few moments here, I would love to ask about the applications processing that you're having in the state. And you'd said that you are ramping up capacity and hiring additional staff to move applications. Can you give our listeners a picture of what that looks like and how you are positioning as a state to increase the intake and usage of the program?
Right. So one of the things that we are doing with having extra staff on board is to focus on populations where we can get the assistance out quickly, and those are folks who have applied for utility assistance. There's less moving parts there because you don't have to have agreement from the utility. So the staff that we're hiring, and it's interesting, when I looked at the data around how many have applied for just utility assistance, it's really quite high. It was over 25% of our applicants had applied for only utility assistance. And so, and then of course there is a large number that have applied for both rent and utility assistance. So one of the things that we're being strategic about with our staff hiring is getting those that have applied for utility assistance, getting them assisted quickly, so that our community partners who are in the community can spend more of their time with getting the landlord-tenant agreement signed and getting the rent paid. So it's sort of divide and conquer at this point.
Thank you for sharing that.
Yeah, can I add something to that? Because I think that's a really important point. Some folks might remember that the last time we got sort of recovery funding for people experiencing homelessness was the Homelessness Prevention and Rapid Rehousing Program, or HPRP, in 2009. And what Haley just said also played out there. A fairly large number of households asked for assistance to pay utility arrearages. And when we dug into that a little bit, we really saw the thing that I think Matthew Desmond says, the rent eats first, is true. People will pay their rent first and not do other things like pay for their medication or pay their utilities. And so to the extent that we are sort of looking at household need in a comprehensive way and allowing, as Haley mentioned, like utility assistance and arrearages to go forward, I think that's incredibly helpful in those situations where people really are just struggling to make ends meet in different kinds of ways.
Thank you for sharing that, Anne. That is a very powerful quote, and I read the book Evicted, and it still sticks with me today. So thank you for sharing that to our listeners. We do have a couple questions in the queue. I want to first go to a question we received from Nick for Haley. The question reads, are you seeing any trends in the number of landlords participating in the HOPE program? And do you have any plans for future incentives for landlords to participate?
So it's interesting. I just did an interview with a media outlet earlier today because someone had reached out to them because their landlord is refusing to take the money. And we are seeing that episodically. But luckily, or fortunately, we have over 750 landlords that have entered into agreements to get assistance. So over $3 million has gone out to pay rent assistance for our program already. And so we're hoping that landlords will take advantage of this program. I think that Governor Cooper's order was absolutely key in getting landlords to the table on this. And of course, we are very concerned when the moratorium expires, and are hopeful that the CDC will do more. So at this point, we don't have any plans for incentives, but we are carefully monitoring what we're getting back from landlords. Sometimes landlords, they don't want to participate because they don't like the condition, but sometimes it's an issue with the tenant, and they don't want to give up their right to be able to evict that tenant. So sometimes it's hard to pinpoint exactly what the problem is, whether it's a tenant specific problem or if they are just unwilling to have that protection for the person for non-payment of rent for that additional period of time.
Thank you, Haley, and thank you, Nick, for your question. I do have another question for all of our speakers, and Barbara, I want to give you the first opportunity to respond. The question comes from Paige. What are some pointers you can give for a rural community who is wanting to address the homelessness situation? Looking at building tiny homes, do you find this is a good idea for rural communities?
Rural communities do have some special considerations, particularly because you're not having those infrastructures of large shelters or many different service providers come into the table. And so you might have rotating church basement kind of shelter situation, largely run by volunteers. And so right now with volunteers and being safe, and so there's a lot of considerations that create more challenges there. I would say, though, that bringing together the folks in your community, your local health officer, your emergency planning, to the table with the providers that you do have. You probably have a federally qualified health center or some health clinic, a behavioral health, an outreach or case management provider, someone who is doing your low-income housing, just whoever you have in your community. I think the principles are the same. It's coming together and it's figuring out what plan can you make to go forward to create some improvements. And even if you can't do the ideal, like what Anne described in terms of, getting all your vouchers and identifying folks and getting them right into housing, like if that's not your immediate reality, thinking about how can you do harm reduction from where you are. So if you've got encampments, how can you make those encampments safer if you don't have maybe a more stable place to put folks, or if folks are unwilling to go there? You mentioned tiny homes. I think tiny homes, again, a lot of this depends on the details, right? Tiny homes can be absolutely decent, affordable, quality places to live. But often what we do is we create tiny homes, we put them behind a giant fence, and then we call them, oh, well, this is a program just for people experiencing homelessness, which is kind of just like a spread out shelter behind a fence. And so part of it is tiny homes can be an affordable option for lots of different people in your community. So the idea is recognizing people's housing choices as anything else that people would have in a community. Having access to a tiny home or an apartment or something like that. Again, just making sure that we're not kind of segregating people into a program and then just like instead of individual rooms, they have individual huts. That's not appreciably different. But just again, thinking through how you can take the resources that you do have, the partners, and making a plan on going forward. And my colleagues might have more to add to that, but that's definitely where I would start.
Thank you, Barbara. Haley, Anne, do you have anything else to add?
I would just note that I agree with Barbara on tiny homes. In some places, I've seen them done really well. In other places, I've seen things that look more like tiny sheds, which I don't think are a real viable, affordable housing option. Or I've seen a situation where like it's really used to segregate people experiencing homelessness from the rest of the community. So the details are important. It could work. But I do think that hopefully over the next few years, we can actually focus more on rural homelessness. I've had some really good conversations with the Housing Assistance Council and others who work on this issue all the time and are trying to come up with some ideas to fund some additional, especially capacity building for organizations to do development in rural areas. So I think it's an area that we're going to start to focus on more and more nationally.
Thank you, Anne. Going on to our next question here. And yeah, thank you for your response page.
Yeah.
So our next question is from Stephanie. Oftentimes people who are experiencing homelessness have been deemed ineligible for federal assistance because of certain criminal convictions. Have you found a way to assist a segment of the vulnerable population? Perhaps Haley, we can start with you for your state perspective.
So our program doesn't ask about criminal history at all. That is not something that we're taking anybody who needs help with their rent or their assistance and is low to moderate income, because it's, you know, as I said, we want to help everyone who needs help staying in their home.
Yeah, I would also say the only area of federal assistance that I know of that does have sort of statutory limitations in this way is there's some on public housing around certain types of convictions, especially drug convictions. But other than that, a lot of those rules are placed on the program locally, even though lots of folks think that they're federal rules. So I would just sort of double check where that's coming from and talk with your state officials about whether that's in fact a federal rule, whether that's something that can be waived at the state level.
Thank you, Anne, and thank you, Haley. The one question I want to go actually back to you, Anne, and invite the other speakers to weigh in. What data should state leaders be looking at to determine if they're making progress for homelessness in their community?
Yeah. Yeah, data is such an important issue in all of this. And in my presentation, I touched on a couple of things. If you are a homeless services system, you are obviously collecting data in your homeless management information system. And there are a set of data that have to be collected for that purpose. So I would certainly start there, but I would also really encourage communities to be looking at some COVID sort of specific data that will help you understand what the impact of these programs are. So again, we can learn from it. And specifically, I would say disaggregating your data by race and ethnicity so that you can understand the impact of certain types of interventions on communities of color and highly marginalized communities. So that you can make adjustments as your program matures or changes, or if you want to apply these kinds of learnings to permanent programs in the future. So if there was one thing that I would look to and sort of pick out is that not just collecting the data on race and ethnicity, which most folks are doing, but really looking at it in that disaggregated way. But I'm sure my colleagues have other thoughts on data too.
I would agree to all of that and add that many states have got an interagency council on homelessness or other bodies set up to look at this issue. And there may already be metrics that have been established prior to COVID. So maybe building on what data structure might have already existed and gathering that information. Another opportunity here, particularly in the healthcare system, is to look at housing status in the healthcare system. And so be asking, how can our hospital systems and how can our other healthcare providers be asking about housing status more often as part of their standard screening and intake, and be coding that in the patient's chart. Just want to make sure that we're kind of using the data that we have, because so much of our healthcare decisions is driven now by data, and getting some of those social determinants, that Z59 code for the healthcare geeks in the crowd, getting that into someone's patient record can be a flag for more thoughtful discharge planning, and can really work more to make sure that someone is discharged in a way that's more stable. So those are just two things, is using existing groups and then thinking how your healthcare system can't do more with coding.
Thank you, Barbara. Thank you, Anne. Barbara, I have one more question for you to close out today's webinar. You know, given everything that's going on, many states are overwhelmed and they're just trying to figure out how do they get through COVID and see through the next day. So why focus on these state systems level solutions for such a short-term problem?
I completely understand that we are all just putting one foot in front of the other and figuring it out as we go. And it seems like every week we've got a new challenge coming to us. At the same time, we are all showing up and we're trying to make these decisions to make the best of our situation. So this is an opportunity for us to make longer term improvements rather than just write what's in front of us. And so thinking through, how do the partnerships that we're establishing, the memorandums of agreement and who's doing what in our community, how can those be longer term improvements in how people are accessing healthcare and housing? How do we want our community to look after COVID is gone? And we know that we can, that will happen at some point. Can we be in a better space in our communities, in our state, in our country, when this is over? Can we look back at this and say what we did during that crisis made our country better? And I think we have an opportunity to do that now if we're really being thoughtful and outlined a structure and a framework that allows us to see beyond the immediate and think through more longer term successes. But I'm really hoping that that's something that we look back on and we're super proud of the advanced progress that we made. And it might be my colleagues can add into that, but I'm just excited about the potential here.
Thank you so much, Barbara.
No, I think that was right. That sounded right to me. I don't have anything to add.
Perfect. And thumbs up from Haley. Great. So to close, Anne, Barbara, Haley, thank you all so much for giving us your valuable time this afternoon. I already see that there's interest for follow-up, but of course, if anybody has any questions and would like to follow up with any of our speakers, please feel free to contact myself at camritt, that's CAMRITT, at nga.org, and I'm happy to put you in touch with any of our speakers. To continue the conversation on equity and policy preparedness during public health emergencies, please join us for the upcoming webinar in this series. The next and final webinar will focus on people who are incarcerated and will be held on Thursday, December 17th at 2 p.m. Eastern. The registration link for this webinar will be sent out following today's webinar. We look forward to your participation in future webinars as well. Thank you again for our speakers and our audience for your participation. We hope to have you involved in participating in our future discussions. Thank you so much and have a great day.